We do.
Oh, great. Thank you. Okay. So the reason I decided to revisit this is two. One, we had a request from Greg to come and speak to us about some of the changes, very important changes in anticoagulation. And I thought I would, and then we also had a bad outcome in the spring with a patient who was cardioverted and ended up having a stroke. They were not anticoagulated post-cardioversion. And so I thought I would talk about this. I did talk to Luke and Kivish, who are developing a guideline which isn't quite ready yet. And so I wanted to know if there was something we could do to close the gap in between, you know, having a robust guideline for us in the department and providing safer care for these patients. I don't have any conflicts of interest to declare. Last year when I did this presentation, I looked at three things. We looked at rhythm versus rate control, pad positioning, and anticoagulation. We're not even going to go through all those same things again because one, anticoagulation has been covered to some extent, and we will touch on it in terms of what the guidelines recommend. The pad positioning, last year we found that there was no difference. There's one more study that came out this year, and that was the Ian Steele study in the Lancet of 2020. They looked at outcomes in patients with electrical cardioversion in the emergency department. They had this was actually a randomized control trial. It was a good trial. And this was one of the areas that they were looking at, which was anterolateral and anteroposterior. And if you look at the results, basically that 93% for shock only converted with the anterolateral, and the anteroposterior was 95%. So there's no difference. And they did the drug shock only, same results. And so this is the sixth study that's had a look at this. And there are a couple of them early on were done. They were retrospective studies, and they did show some difference. So back, I don't know, about 10 years ago, we were all keen on doing the AP positioning, but that hasn't borne out in future studies. And so, you know, it's usually easier to put the anterolateral pads on. And so they recommend that we do that and put the AP on if it's not working, or vice versa. If you have the AP on, it doesn't work, you can change them. Most important part that they talked about in this study was, you know, proper positioning. And so this is the top one is the anterior posterior to make sure that it goes straight through the heart, and anterolateral to get that position done well too, because sometimes they're a little too close together and you're not going to get as broad of a coverage. So I spent a lot of time this time when I looked at this problem, looking at outcomes for patients with atrial fibrillation, because I think that's what we want to know about in emergency medicine. We like to do things that are going to help our patients, and we like to do things that are evidence-based. And sometimes there's not a lot of evidence around what we do, and so we do what we've been doing for a long time. And some of us get a little bit used to doing that, and we forget about, you know, are we doing something that's really valuable for the patient, and what are the harms associated with doing something or not doing something? And most of the studies are retrospective studies. The Ian Steele study that looked at 1,000 emergency patients in Canada was a prospective study. And all of them look mostly at emergency department visits, hospitalizations, heart failure, death, and stroke. The reason is because I think these are pretty easy to measure. And a lot of what we also think about though in atrial fibrillation, because especially when you look at the rate versus rhythm control group, is, you know, how do the patients feel? What's their quality of life? And if they have to wait for 3 or 4 weeks before getting cardioverted, is this a problem for them? And those things are a lot harder to study. And so it's not really something that has been looked at well. But I think it's important. It's an important patient outcome. And so that's something that I think a lot of emergency doctors think about, is if we can do something that's going to help the patient in the short term, that's important. And so that sort of drives, I think, some of the aggressiveness in terms of cardioverting these patients. And then I think you have to look at, well, is there any harm involved? And I think that's what some of these other studies are looking at. And the biggest problem, I think, has been with the stroke. And so that is why there's been a lot more emphasis lately on, how we anticoagulate these patients. So these are some of the more landmark trials. The top line was the FIN-CD study, the cardioversion study done in Finland. And they looked at 5,000 patients with cardioversion, electrical cardioversion in the emergency departments. And the more recent one in Canada was outcomes, and they looked at 1,000. And what I found interesting between these two is that the Finnish study had 38 strokes or systemic embolisms, and the Canadian study had 1,000 patients with only one. So big difference in the number of strokes that were seen. And so I think that creates some controversy in the Canadian guidelines, I think, especially in CAPE, on, how important is this stroke risk. But at the end of the day, and if you look at Infield's latest article, which is the 2021 that I just talked about with pad positionings, and he's more in favor now of saying, well, if there is any possibility that there could be worse outcomes, we should be more tentative about acute treatment. And so he's lining up with the CCS as well. So, I mean, we look at the bad outcomes. What are our goals in treating atrial fibrillation and flutter? And some of these are outpatient goals, in terms of underlying structural heart disease. We can try to find predisposing conditions in the emergency department, and I think that's the very first step. And I'll talk about a study that emphasizes that. We want to relieve symptoms. We want to improve their functional capacity. We certainly want to reduce any morbidity or mortality associated with atrial fibrillation, and importantly, we want to prevent the stroke risks. So this is from the CCS website, and I think this is a great place to go because they have a couple of really great tools for us. One is just the e-guidelines, so you can just go online and you can just look under the e-guideline, and they have all this information in these nicely presented tables, which we like in the emergency department because we don't have time to read through a lot of detail. We just want to have a pathway that is clear for us and safe for our patients. And so I wanted to start with this pathway over in this corner up here, and that's detecting and treatment of precipitating causes. This is as valuable or even perhaps more valuable in the emergency department than in the outpatient setting, especially acutely. And so before we even, think about stroke risk and management of arrhythmia, what's going on with the patient? What else could be going on that's not a primary rhythm problem? And this is a nice study that was done in Canada in 2015. And what they looked at was people with AFib flutter and an acute underlying medical illness. They had 145 patients in the study that were had atrial fib or flutter controlled. Well, let me just think about this for a second. I think I have the wrong number there because they didn't all get rate. Some of them got rate controlled, some of them got rhythm controlled. So we'll see that in the next slide. And then 28 of them had neither strategies, and they looked at the safety of rate or rhythm control. So they looked at the adverse events in these groups, and they also looked at the success of rate or rhythm control within 4 hours of treatment. And this was a retrospective chart review, which has all the problems associated with that kind of a study. But this is what I found impressive in this study was that when they looked at adverse events, so this is the numbers I was thinking here, in the rate/rhythm control group, there was 135 patients, and 55 of them had an adverse event, which is 40%. And And in the not controlled group, so of these people who came in with atrial fib flutter and a complex medical illness, 280 of the 81 of them had no control or strategies, and only 20 of those had a bad outcome. Oh, hang on a second. There's somebody who is not muted. And somebody. Okay, sounds good now. And so the risk difference is 5.7. So you're almost 6 times more likely to have an adverse event if you have a rhythm or rate control strategy applied to you in the emergency department when in atrial fibrillation or flutter and a complex medical illness. This one breaks it down just to show the difference between rate and rhythm control. And there's really no difference. It's 40%, 40%. So it's a 40% adverse event when we try to manage the rhythm with these people rather than treating their underlying medical condition. This one is also really impressive because here we are doing something that's potentially causing harm in a lot of patients, and it's not really very successful. So if you look at what people in the rate control group, out of 105 people, 20% of them had a successful control of their rate. And in the rhythm control, 13% were successful in controlling the rhythm. So we're throwing drugs at them, or we're trying to cardiovert them, which so involves throwing drugs at them so that we can sedate them. And we're not very successful. And we're causing bad outcomes. So I think that is a kind of powerful reminder, despite the fact that it's a retrospective cohort study. Those are big, convincing changes, and so it makes me think really carefully now about the kind of patients that come in with atrial fibrillation and doing a proper assessment first, which I'm sure we do, but to really think hard about it and clear about it. These are the kind of complex medical diagnoses that were found, and hopefully there are some that are relatively easy to spot, but not all of them. And so it tells us that we have to hunt a bit before we run in there with the procainamide or the electrocardioversion pads. Or with any kind of rate slowing drugs. And what this reminds me of to some extent is, back in the day when we first started doing lots of intubations in the emergency department, we used to intubate everybody. And then at some point in time, we realized that people are having some pretty poor outcomes from intubation, and they are the really sick people. The people we thought, need to be intubated immediately to start with. And, then we recognize that people who have hypotension, who have hypoxia, who are severely acidotic, even though they're having issues with breathing, we should resuscitate the patient as well as we can before intubation, and that's going to make the patient better. And I think you can probably apply the same kind of thinking here, is that these patients who are acutely sick with medical diagnosis, we need to do something different first. And so we want to concentrate on resuscitating the patients and then proceeding to think about their rhythm after that. And these are the adverse events that they saw. So they needed to have, inotropic agents, they needed to be intubated or have positive pressure ventilation, bradycardia requiring pacemaker or drugs, and strokes, chest compressions, or death. So pretty impressive events. So that's what I wanted to just focus on initially, is make sure that we're doing this correctly first, and then we can actually move on to the rate control versus rhythm control thought process. And so this is the same guideline that we saw with Greg's presentation. And this is really nicely done. It's way easier than the CAPE guideline, and it's online. It's something that we can access immediately. And it goes through the pathway, which we talked about in terms of, who shouldn't be cardioverted in the department. So all these guys, we can think about rate control and and certainly anticoagulation, and then follow-up. People with valvular AFib of any duration, people with non-valvular AFib that have less than 12 hours and a recent of the duration less than 12 hours and recent stroke or TIA, or if they're in the 12 to 48 hours, but they have a CHAD score that's 2 or greater, or outside of the 48 hours. And, you know, it was really simple for us a while ago, where it was just kind of outside of the 48 hours, inside the 48 hours kind of decision pathway. And now we see it's a little bit more complicated. And so we should probably be following an algorithm to help us make the right choices here. They still say hemodynamically unstable acute AFib should be cardioverted quickly. It used to say immediately, and now they are saying urgently, because they're recognizing that there is this value of seeing if there's something else going on in those patients that we really need to resuscitate and treat before we just go ahead with the cardioversion. And then the lower risk groups, we're going to be able to cardiovert. They suggest that we initiate the anticoagulation as soon as possible, and preferably prior to cardioversion. So this would be one of the drugs that we would give even before we do the propofol, fentanyl, or in the case of a drug cardioversion, the procainamide. And then to our question earlier was really, we probably should anticoagulate all these guys for 4 weeks and have them follow up with cardiology to determine their long-term anticoagulation requirements. In terms of rate control, this is also on the website. I'm going to show you the website in just a second because it's really beautiful. It shows, you know, there is a bit of a difference between what medications we should use based on whether the patient has heart failure, coronary disease, or neither. And then they have a nice little table in there which has the drugs, the dosage, and the risks associated with them, which all of us are pretty familiar with in the emergency department. And then they have the CCS algorithm, and this is for patients who one, were either are, you know, having non-symptomatic AFib that was discovered while in the emergency department, and we're not going to cardiovert them, but we need to think about anticoagulation for them as well as they await proper follow-up. Rhythm control. You know, I really just talk about procainamide and electrocardioversion. That's the most common that's being used, and it's probably what we would stick with in our guideline. And so post-treatment, I think we should go ahead with all will need anticoagulation outpatient follow-up. And the question, you know, like a lot of patients in the last 10 years, we're still having follow-up with family medicine versus cardiology. And this is something that we just spoke about and that we need to address in our own pathways, that, you know, because we are having trouble interpreting some of this new evidence around what to do with these patients in atrial fibrillation, what their risk stratification is, you know, what their underlying causes are, how to work them up. And I think that family medicine, there's a lot of physicians out there who are not current in this literature. And so it makes sense to me that we should have a cardiology follow-up. So basically, in summary, the anticoagulation is essential. Pad position, there's no difference. Rate versus rhythm management, we really need to seek to treat underlying causes first, and then proceed with a rate versus rhythm management strategy, and we should follow the CCS guidelines. So I am going to see if I can share those with you here. Let me just. Okay, hang on a second. Share this. Here we go. So this is the CCS website. Let's see if I can just. I got us in the way here. So really, what I go to here is the guidelines area and the e-guidelines. In fact, even before I go there, there's a guideline resource page. It has all these resources. The e-guidelines are also in an app, so you can go to one of the apps, which I think is called the ICCS. I figured there's a lot of stuff in there. It's a little bit like the thrombosis app, so use that. It's probably a good one to put on your phone or your pad, your iPad. I think it's a bit hard to get to all the details, and so I like to use the online one, but then you have to actually get to a computer to do it. And so I